Thank you, Israel. Thank you, Mike, for having me. I'm very humbled to be here. Gosh, what a great group. It's very humbling to speak in front of y'all. I'm just a dentist with a passion for aesthetics and cosmetics, and especially in the implant realm. When I look at teeth in terms of central incisors, Mike said, Johnny, you're going to speak today on the perfect central. It's like, gosh, Mike, you couldn't have given me, restorative decisions and from a physiologic perspective or something like that. To create a perfect central incisor, does it ever happen? The best answer I have is the perfect central incisor is that one which fits, the one that works. Excuse me. So I work within what I call an aesthetic keyway. I work from shape and color. It's on my mind all day long. Shape and color, shape and color, shape and color. And that defines how every case becomes, from a molar to all on X to whatever, to gingival tissue. So the aesthetics keyway with regards to central is the points of concavity, which are, when you think about, I was trained by the Japanese masters in ceramic. When you think about a central and to lateral to canine, think of it as a flower. It's blossoming. It has a neck to it. And that neck is the points of concavity. That's where everything begins. If you want your work to look natural, it has to blossom. It blossoms like this. So from there, you have what we call the rule of three. Every cusp is made in terms of a rule of three. 3 developmental lobes, 2 proximal, 1 central. So every cusp has a rule of 3 associated with it. That rule of 3 gives rise to the proximally directed concave lines. And those lines are what creates the natural beauty of the tooth. So not only do you come from a point of concavity where it's blossoming out like this, but once the proximally directed concave lines, once they actually reach the contacts of each tooth, then it turns in like this. So you have this beautiful flower arrangement and it turns in. And that's how you create these beautiful J shapes where you see the shape. And you can see how when you look at the, I do this right? When you look at the strobe, the light of the camera, it picks that up. So that's how you can determine whether your work looks good or not. There we go. So the next keyway is color. Now, when you look at color, look at where the basic shade is. I will tell you that I have not used a shade guide in 35 years. Willie Geller, probably the most talented ceramist and popular ceramist in the world, says, I don't use shade guides. They mean nothing to me. Klaus Mudity says the same thing. So they mean nothing, but this is why. Because color, and yesterday we had a little conversation, a deep conversation about using PMMA and other things. This is one of the reasons why I think PMMA has its place as a permanent restoration in the geriatric population, because vitality is not as important to them anymore as I want to keep my teeth, I don't want decay, it's an easy resolve to decay, that kind of thing. But this is why we use ceramic, because we can create this beauty. And at the same time, look what we have. We have a halo, which has 2 different colors, ivory and white generally. We have translucent washes, which is the thickness of the enamel that's creating that. So it's a physiologic reason why these colors are here. We have translucent zone, which is unsupported enamel. It's enamel that's not supported by dentin. And so you create this blue smoky color. Then you have the mamelons, which can be white, pumpkin, or salmon. Beautiful colors, absolutely beautiful. And sometimes you won't even see a mamelon. And it's like a default, the basic shade that you see. You also have the high value area. This is one of the things that I love about zirconia, is that the high value area, you can place it in the right spot with very little color to it. It just does it naturally. So you can also place interproximal colors of copper, clementine, like an orange color, that kind of thing. And in the cervical or neck of the tooth, which is essentially the root color, is what you're dealing with. Could be ABC or khaki color. So these are the things, shape and color. Now, what's more important, shape or color? Well, the human eye recognizes straight lines over fuzzy boundaries. So you got to think shape is more important. So color is secondary. But from a secondary perspective, the shape of color becomes just as important in aesthetic cases. So these are the colors. Look how beautiful. You see a basic shade in there? I see A and B and C. So we use a little bit of every one in every tooth. So you're going to have a situation where you might use 10 or 12 different colors. Now, the technique that works best in my hands, and it's easiest, is something called the internal live stain technique, which was popularized by Aoshima in about 1996. I still use it today. It makes sense because color has shape to it within the tooth. I build a support, I build a foundation. On top of that foundation, I build the color, and then we put kind of like the analysis, I put a glass over it. That glass is a thin layer of enamel, and that kind of mutes the color and allows vitality. So I just place this as a place marker in case somebody wants to see. It's not a part of the, solid part of the lecture, but it's just matching an existing single central. Is it perfect? Yes, it matches. It fits very well. You know, is it a bleached dentition? Yes, that's a totally different lecture. But for the most part, with a bleached dentition, you're creating what Shigeru Kataoka called a milking effect. It's like adding milk to water, is the way he describes it. Then you have a case like this, where failed restorative decisions, I think the previous dentist maybe tried 6 or 7 times to replace this crown, couldn't get it right. And the laboratory couldn't get it right. I don't know why. Anyway, when you look at it, look at the colors. Look at the wash of blue. Look at the translucent zone. Look at the mamelons. I see like an ivory colored mamelon. I see a pumpkin colored mamelon, a salmon colored mamelon. And up at the cervical area, we have this bright yellow, almost like a sunset color. And you see it in the mouth. Why did we place that? Because it's there. Klaus Muditis told me that one time. I said, why did you put that color there? And he looked at me like, are you crazy? Because it's there. That's why. No other explanation. That's what we see, we place it. The Japanese masters, when they teach more from a reason why it's there. So, but let's get on to the body of the lecture, which is this tooth right here. Mike's and I worked on this case, and we have a fracture number 8. And you look at the dimensions of things, and let's analyze this first of all. Tooth is fractured, has to come out, going to place an implant. Bone grafting, well, Mike, I'm sure you did some bone grafting on this, I don't recall, but look at the tissue heights. We have an aesthetic dilemma immediately. And also, let's analyze 8 to 9. What do we see? We see 9 has a smaller width than 8. Is that natural? Absolutely. You'll see it all the time. 0.5 millimeter difference between widths of 8 and 9, all the time. You'll also see up here, is this right? Which one? I don't know which one, but I don't know which one of these is a pointer. However, look at number 9. You're going to see a square cervical component to the CEJ. Look at number 8. If you look at the CEJ, you're going to see like a round cervical component. So I always say there's a square central and a round central on every one. You'll always see a square central and a round central. I don't know why nature puts it there, but it's there. So once you create a round central and a square central, or you identify them, I should say, then you're ready to know what to do with them. So in this case, we have an issue of, do we have enough bone? The answer is, well, is it going to be practical to place a lot of bone grafting and wait for it, and then maybe one day have it fail. I think in Mike's wisdom, he chose volume plumping with the tissue, which I think was a perfect idea. So we do some volume plumping. Now that becomes when you place an implant, and now you have we have a Ditron implant in there. And what is the restorative decisions? Custom abutment, tie base, anything else? I like tie bases, and I'll explain why in just a moment. But look at the picture on the right. Look at the angle at which the root is coming off of that tooth. You would think that's unnatural, but that's nature. Nature always surprises you with what it does. So we have a little toeing in of the teeth. So what do we want to do? We want to build that out a little bit. Is that a good? Oh, thank you. There you go. So you can see we have the angle here. Pay attention to that angle. Because we have the toeing in. We want to, of course, build this out because I always feel like I use a theory called, it's popular in plastic surgery, called the theory of deproject, reproject. I want to deproject the arch form that I'm working with in order to reproject. And with deprojection, I get rid of the inconsistencies of what I don't like. And then with reprojection, I build it back up to where we want it. So what we want to do is get rid of the toeing. We want to essentially bring this tissue down, which Mike did beautifully. You'll see in the final result. And so we begin this with an analysis. The analysis begins with the temporary. The implant's uncovered, got plenty of tissue to work with. I'm using a Ditron non-engaging abutment. I don't care if it wiggles at this time. I just want to get it right. I use as a base for this temporary that he's been living with a Ribon bridge fixed component for about, 4 or 5 months. So I just take that, connect it initially so I can get everything squared up to where I want. And then I can start adding flowable composite, regular composite. And we've been having him bleach with a home bleaching kit because everybody wants whiter teeth. And so, we get it? There we go. So this is what it looks like. The shape, in my opinion, this is what I believe why I like tie bases and why I think the shape should look like this. We're not far off from a natural dentition, really. And what we're doing right here is I'm allowing as much tissue to surround this implant, the emergence profile of it, as possible. So that's my goal. I don't want to stress the tissue. I don't want to make it, expand outward. I want it to be comfortable. What's its nature? To actually cover the implant. So I'm going to give it as much room as it wants. And that plumping helps out a great deal. You look at the work of Jonathan Esquivel, and you'll see a lot of this information. He calls it a popsicle on a stick. That's what he creates. So here's our analysis of our temporary. This is why we place this. Every temporary becomes a study of what's happening. And what's the importance here? Well, I line up the midline. I get it. Look at the tissue that's come down already. And look what we see. We see a diastema because of the toeing. So if I make this tooth 8.5 millimeters and this tooth 8.5 millimeters, and they look pretty similar, I have to laminate this tooth. I have to veneer it and or crown it, whatever is best. So that's what we chose to do. We're going to veneer it. So we put a temporary on it, just connect it to here, and to see what it looks like. Looks okay. So we'll prep the tooth for the veneer, number 9, and you can see what it looks like as we scan. This is the temporary. And look at the tissue, how it's come down. It looks great. Look how square this is. It's normal. Don't try to make it round. It's square. So this is the flag, the scan body. and in relation to the temporary. So we can see how things look. Mike did a beautiful job placing this implant. Thank you, Mike. It makes my job much easier. That's what it does. So this is why I like tie bases. Look at this from a strictly cosmetic perspective. If we placed a custom abutment, how far is the metal going to come up in here? Maybe to here, maybe to here. Look where my tie base, look where the metal ends. So look what I have transmitting, look how much ceramic I have transmitting light. Everything. Therefore, when this person is in a disco, it's going to look natural. When this person is on the beach, it's going to look natural. When this person is in a room like this with ambient lighting, it's going to look natural. That's the beauty of this. It will match the surrounding area. So this is our proposal. Notice the rule of three. Always, as a rule of thumb, the distal developmental lobe occupies 1/3. The mesial, the mesial developmental lobe is going to occupy 1/3 of the width. The distal and central developmental lobes occupy 2/3, with the distal developmental lobe occupying more than the central developmental lobe. That's a typical rule of thumb that you'll find in almost every case. So we bring the towing out, we bring it out, make it look more like this area here. This is the proposal from the implant perspective, and you can see how much tissue we are allowing this. It's very passive. We want it to be very passive. I don't want to stretch the tissue. I don't want to see any blanching or anything. So this is a relationship of our clinical crown to our tie base to our implant. And look at the emergence profile. Absolutely perfect. Coming right off the cingulum. I couldn't ask for anything better. This is what it looks like finished, our proposal. And look at this little neck. This is how you define the outline of the tooth. That's 0.5 millimeter. That's all it takes to define the outline of the tooth. It doesn't require a big area here. So we have this, notice the implant. Esquivel says you should have 1.5 millimeters, ideal, you know, from of the tie base. And then we have even more because of the depth at which it was placed in bone, which is beautiful. So we don't want to bother any of this area. We want to make sure that it stays as passive as possible. So let's get on to the aesthetics of it. We add our mamelons. We add our enamel layer, and that's my foundation for the color. We go to the veneer, add our veneer colors. This is enamel. We're going to take and shape it to make sure we have a proximally directed concave line. Here's our points of concavity. We want to make sure we have that nice, beautiful movement to it. It's essentially an S shape that turns in. This is for the crown. Then what I do, what's interesting, many times for a case like this, I could guesstimate what he's going to look like on a bench top. But if I have the patient, let's do it in the mouth. So we place some smoke, some azure, translucent wash, translucent zone, and we'll start building this color to match what we see here. I actually have many, many slides of that, but just to cut it short, we have our color. You see our halo. We see some ivory-colored developmental lobes, mamelons, and you see the colors in here. This is the brightest part of the tooth. That's what we want. Let's go ahead and do and you can see how we relate to our aesthetic, our cosmetic, our color keyway. You can see how we relate. This is my interpretation of this. So this lives in my head 24/7. Every case I do, no matter it's bleached dentition, matching a single central, doing 10 veneers, doing all on X, this is in my head for every tooth. And it's how you create this interpretation for the rest of the mouth. So let's do the veneer. We'll place the nice, this is a like an A2 color, but it's just shade A. And we'll place our wash and zone. We place our halo. And there it is finished. Well, not finished, but the color portion is complete. We just have one layer to place on top of this, and that's an enamel layer. But you see how we captured central should be a little bit brighter than the rest of the mouth, because they're the most dominant teeth in your mouth. You want your centrals to be the brightest. You want your canines to compete for that dominance, but not overpower it. Then you want the laterals to simply fill in the space between. That's a famous quote by Jerry Sheesh. So this is what it looks like up close. Notice you see that dark line. This crown is not attached to the tie base yet, so it slips down a little bit. The reason is I have to fire it. I have to finish firing it. So that's the importance here. So, but when we finish, it'll be right up here. This is what it looks like finished. And you see how the color is a little more muted, but they still show through. You can see the beautiful neck. You can see we transferred this from a non-engaging abutment to an engaging abutment. You see it. And you can see the beauty of this. Highly polished. Of course, it's because of the placement of the implant in a proper place. I just screw it in, and we have, this is at the time of placement. This is immediately at placement. Literally. We clean it up. This is what you have. Look at the tissue up here. It's beautiful. And this is it when we, after it matures and we're able to see, but you can see how beautiful the finished result comes out. Now we have a perfect central. It required 2 perfect centrals, but we have a nice result. Any questions? Yes. What material did I use in the temporary?
What material did you use for this? So we like to see the communication in zirconia. When we send those files to the neighbor, they send us the whole layer of ceramic. We would like to get a couple of work of that. What do you, is this lithium silicate, correct?
Is this lithium disilicate?
Yeah.
No. This is Prime. It's an Ivoclar product called Prime. It's zirconia.
Yeah, I know it's beautiful work. Outstanding. What I see is the end cord for the tie base. See, the end cord is very, very short. What material is that? Because I see you build a crown on top of that. You take the crown from the patient's mouth, fire it, come back in and try a couple of things and adjust it. What is the material? As I see the tie base connected to it. What type of bonding is that?
Oh, what is the bonding? What is the cement? Is that what you want to know?
The tie base is cemented to the abutment. I see something like a connection to it. You build the whole crown to this cord who holds the whole ceramic.
Yeah.
What material is that? Is the center, how did you build that tie base? So the tie base is only very short.
The tie base is about 7 millimeters. I think 6 to 7 millimeters. It's very short. Yeah. That's all you need though. Well, on the tie base goes the entire restoration. Thank you. I hope y'all understand the question. The question is what is placed on the tie base? It's the zirconia restoration. What you see, that neck is zirconia. It's cemented with either Panavia, Multilink, whatever I have in my hands at the time. What is my stain technique?
Stain kit, is that all the colors you have, is that a particular kit, or do you mixed a bunch of?
No, the question is, what kind of stain kit do I use? I use many different stain kits. This one happens to be Mio by Jensen, M-I-Y-O. It's very versatile kit. It's easy to use. It's quite extensive. And in fact, for all on X cases, I like using it because you can actually place a gingival portion at literally 0.2 of a millimeter, and it blocks out, creates a beautiful result. Like the picture you saw from Mike this morning of my work, that it was an all on X on the bottom, and the pink was is probably 0.2 of a millimeter thick, 0.3 of a millimeter thick. So, yes.
This is amazing. What advice would you give a restoring doctor that is maybe working with a dental laboratory 20 miles away? What records, data, information?
Great question. Yeah. One of the toughest things to do is to communicate with your laboratory. Best thing to do is go fishing with them and get to know them, because you have to think on the same page. And but one of the things you have to do is get into a framework with your ceramist, and that is how are you thinking? You have to begin to think alike. So that's why I like the internal lives thing technique, because when I speak to myself, which is real easy, it makes sense. You know, I learned from many different masters, and it wasn't until I learned from the Japanese that they gave a reason for why things happen. Why does this color look like this? Well, because of, it could be a translucent wash or whatever. They give an answer for it. So, but in this, when you are speaking with your ceramist, tell them this is you take classes with them, take courses with them, and learn their techniques. This is something that I've been teaching since 1996. So a lot of ceramists gravitate to it because it is very easy. And I will say, since the Mio system has come out, because Ivoclar has the same colors, they just never advertised it like this. Ceram, which is one of my favorite porcelains of all time. It's like a Ferrari of porcelain. The porcelain is absolutely beautiful. They have the same colors. So you can do the same thing with it. But when it comes to speaking with your ceramist and interpreting things, give them a picture of that diagram. And if you want, I'll send it to you. The diagram that has all the colors on it. This is what I live by. It doesn't change. In fact, when Klaus Munites once said in 1992, he said, all teeth are made the same. He said, I make them. He said, they send me an A2 shade guide. He said, I make the tooth. What color? You're looking at 14, 15 different colors. That's what he said. And he wasn't being pretentious. He's just saying this is how things are, So one more question.
Advice for sequencing, say if your lab is not that tie base.
Yeah.
But would you get these ordered at the same time? Say there's a
That's a great idea. It's another good idea. A lot of times I will tell you, I've made them. The question is, what if you veneer? Would it be better to veneer the tooth and see what you have, and then come back and do the crown next door to it? And the answer is, it's not a bad idea. I've been caught where I had to replace either a veneer or a crown because of that reason of mismatching, not getting quite right. But so it's not a bad idea. Another thing to recommend is when you build out your temporary, if you want to go to this degree in a temporary, you can by using something called Tetric Color by Ivoclar. It's a bunch of stains, and you can literally take a paintbrush, put it on. When you get the color the way you want it, you light cure it. Keep light curing, and send it to the. You can either send it or take a picture of it to your ceramist or send it to them. So it can be done that way. So one more.
Sending a shade to the lab and say, give me an A2 crown. What do you have to charge for something like this?
What do I charge for something like this? Actually, what's funny is I charge $1,700 a tooth. It's not bad. I don't think it's bad. And sometimes I'll make doubles. I'll make often I'll make 2 teeth because I know one may look better than another. So. But some ceramists I know, like Olivier Trick, I think is one of the most talented ceramists in America. He's French, but he lives in Chicago. Olivier will charge $1,700 to make it. You know, so, but yes.
States like that, are you firing each individual step or?
Good question. Do I fire each individual step? I will fire each layer. So when I place the stains, I will go fire it. When I place the enamel, I'll fire it. So generally it's about three or four bakes and you're finished. Yeah. Thank you all very much. Appreciate it.